Our next speaker is Dr. Rafee, who's the current Dystonia Research Fellow at St Vincent's Hospital. He's a graduate of Trinity College Medical School and is completing a PhD with Professor Michael Hutchinson, who many of you will know, and Professor Richard Riley. He's a really stellar researcher, and I'd be very interested to hear what his takes are on research now in St Vincent's.
Well, thank you for having me. Thanks to Maria and Dystonia Ireland for putting this together and inviting me back, and Professor Hutchinson and Dr. Fearon for organising this. I've been given the topic of talking about the Vincent's Dystonia research. So we've been doing this now for about, I think it's over 20 years when Professor Hutchinson first started doing this. And it's been a very productive research group, and it's been that way because of the involvement of a lot of the people here and a lot of the people that attend our own clinic. We don't have a service within Ireland like the UK Biobank. The HSE doesn't have electronic records that are national records. We don't have a national biobank, and the hospitals aren't as well linked as they can be. So if you look at dystonia research within this country, it's essentially only happening in Vincent's, and then we try and get some of the other smaller clinics involved when possible. So you already know about all the different types of dystonias. I'm going to focus on cervical dystonia purely because of representation. That's what we see the most in clinic, but a lot of the symptoms that I'll be talking about are applicable to all the other types of dystonia as well. So it's purely because what we see in the clinic, that's why we focused on cervical dystonia. Let me just put this in context about what we know about dystonia in Ireland. It is a rare disorder, and that's been established internationally. The last time we did a count was back in 2014. That was Dr. Laura Williams, working with Professor Hutchinson, who did a nationwide survey involving every clinic across the country which was seeing someone with dystonia, and they counted 592 people exactly with the types of focal dystonias. And if you want to look at the breakdown, about 80 to 90% of them were cervical dystonia, with smaller numbers in blepharospasm, focal hand dystonia, and then very few people with the laryngeal or spasmodic dysphonia, and then a handful with musicians and oromandibular or jaw dystonia. And in general, and this is what's seen internationally as well, there is an overrepresentation of women with these disorders. It's not entirely clear why that's happening. The only exception might be musicians' dystonia, but everything else seems to affect women a lot more. Dystonia has been recognized. If you actually look at historical accounts, it's been recognized since earlier than the Romans. So people have been aware of it for at least 2,000 years. But up until 1970, it was considered a psychiatric disorder. And if you were someone who had dystonia pre-1970, your initial treatment would have been the likes of Sigmund Freud and other psychiatrists. And it helped a little bit. If you look at the studies that are written, the people did tend to improve a little bit, but that's because of what we know now about the impact of non-motor symptoms, that yeah, when you treat the anxiety and depression, it's going to improve a little, but there wasn't really any consideration of this being a neurological disorder until the 1970s, and it was after that that botulinum toxin treatment was induced. And our count of 592 is probably an underrepresentation because we know that there's often a delay to diagnosis. There was an Australian study going back about 8 to 10 years ago which looked at this, and they said people on average are waiting about 5 to 7 years for a diagnosis of something like cervical dystonia. In my experience in Vincent, it's probably not that long. I think it's less than 2 to 3 years, but that's because awareness has been increasing, and part of that is due to the advocacy work of groups like Dystonia Ireland. And many people would have very mild symptoms where they don't need treatment and they might not go and see anyone about it. And it's a complicated disorder. All the focal dystonias are, and dystonia in general as a spectrum is difficult to quantify objectively. And this is something that we discuss as a research group. And from the talks that are going on now in the Dystonia International Conference, we know that it's a disease that affects the muscles, which is what we see, but it also affects the brain and the spinal cord. So it's very difficult to identify one target within dystonia to study. It has to be studied as a network that's affecting the entire nervous system. So, you can present us the motor symptoms, which Dr. Peel touched on, and then the non-motor symptoms, which she went into in detail on. And the predominance of the symptoms, if you're talking about the number of symptoms alone, there's way more non-motor symptoms than there are motor symptoms. And I can't discuss the research that I've done without going into the work that was done before me. So I'll just touch on that a little bit. a lot of the work that we've done initially was focusing on the motor symptoms and then the sensory abnormalities. For the first 5 to 10 years or so, the sensory abnormalities predominated. And some of you would have been involved in the study where you wore a headset with flashing lights on it, and that measured something called temporal discrimination, and those were pretty landmark studies, and they contributed a lot to the dystonia literature and people with dystonia within Ireland and internationally. And a lot of people have built on that work that came out of the work that Professor Hutchinson did in the early 2000s. And then more recently, over the last 5 to 8 years, we have been looking at the cognitive and psychiatric symptoms as well. So the dystonia researcher before me from 2018 to 2020, who a lot of you would have met, was Dr. Dina, who's now working in the UK. And she focused on psychiatric symptoms. And again, this is because of this suspicion that the non-motor symptoms were having a bigger effect on the quality of life and a bigger effect on people with dystonia than the motor symptoms. And we wanted to see what is the experience in our own clinic. And this is the first time that we looked at it. So what kind of symptoms are people experiencing? What proportion of patients with cervical dystonia are experiencing symptoms? And how do these symptoms fit in the entire context of the syndrome of cervical dystonia, which we know is quite all-encompassing. This is a study that I brought up at the earlier conference, but I'll just mention it again. This is probably the largest study that looked at the prevalence of anxiety and depression, and this was carried out by the Dystonia Coalition in the United States, and they included almost 500 people with cervical dystonia, 500 people with focal dystonia, the majority of them cervical dystonia. And the actual differences here don't matter, but if you look at the lowest proportion, it's actually, I think it's around 20%, so almost a fifth at the very least would be experiencing depression and or anxiety. So it's definitely something that's affecting a lot of people. Dina wrote up this paper about 2 or 3 years ago where she looked at the mood symptoms and how that impacted on the quality of life. And it was quite a large study, and it's still one of the bigger studies that has come out of Europe. At the very least, she collected 201 people with cervical dystonia, all from St Vincent's Hospital. And they did a few measures. So let me just go back there for a second. The BAI, which Dr. Peel mentioned, measures anxiety. The BDI measures depression. The CDIP, that's a quality of life score and is very specific for cervical dystonia. Twisters, again, is another survey. These are all paper-based surveys. From a research point of view, this is how they have to be done. Twisters measures various aspects of the symptoms of cervical dystonia, and the utility index is just a generic quality of life index as well. And if you're looking at some of the details of the patients that are attending our clinic, we know that from this study, the mean age back in 2019 or 2020, when this survey was done, was 61. So that's the average age of the people with cervical dystonia attending Vincent's. And Dr. Peel spoke to you about this. We tried to look at what % of people had a mood disorder before they developed cervical dystonia. There's no rigorous way of doing this. This can only be done by asking people. Because we don't have access to GP databases, all we did was ask people, did you have a diagnosis of anxiety or depression before you developed cervical dystonia? And 79 out of the 201, which is about 40%, said that before they developed any motor symptom, they had symptoms of anxiety or depression. And if you're thinking about recall, it's probably an underestimation. I think if people could remember everything about their lives, the number would actually be a little bit higher, I suspect. And the next step was to look at the motor severity. So Twisters 2 is one way of measuring the motor severity in cervical dystonia, and it's the one that's the most widely used. It's a paper-based survey, which a lot of you would have done. And the score is 10, and if you want to know what 10 means, if you look at the other studies, it probably is towards the lower end of the spectrum of disease severity with cervical dystonia. I think Twisters goes from 0 to 24, and just based on some other studies, this will be at the lower end of the spectrum, so maybe in the mild range of cervical dystonia, but obviously there will be a lot of variation. And one of the reasons why this is in the mild range is because a lot of the people, actually all the people that would have been involved in the study pretty much would have been treated with botulinum toxin. So we included people that were being treated for dystonia when we asked them how bad their dystonia severity was. So you'd expect the treatment effect to be having an impact on the score, and that's probably why it's in the mild range. And if you were to say, take people off botulinum toxin for 6 to 9 months and then went back and looked at this, and the same people would have much higher scores. Duration of cervical dystonia was about 18 years. So that's how long people on average are attending our clinic. It was maybe about 2 or 3 years for diagnosis there. But in general, people, once you get established in our clinic, you're there for life for botulinum toxin. I don't know if that's a good thing or a bad thing, but you will be there for life if you want to continue getting treatment with botulinum toxin. And then we look at the Beck anxiety inventory and Beck depression inventory. These are, again, paper-based surveys. We found a score of 11. It is not an insignificant score. It still means that there are prominent anxiety or depression symptoms. But again, if you want to say, is this mild, moderate, severe, it's probably towards the lower moderate or mild end of the spectrum. This score goes from 0 to 30. And we would quantify severe anxiety or depression as a score of over 15. So when we went back and looked at our database to see how many people scored over 15, we found that almost a third of women scored over 15 in the anxiety inventory and around 30% of men. And then again, around 30% of women had a significant anxiety score, and a quarter of men had this high anxiety score. And the people who had both are around a fifth to a quarter of the patients. So that's quite a large number of people that are attending our clinic who are just attending for botulinum toxin but have this dominant anxiety and depression symptoms, which are going to impact on your whole life, and they're definitely going to impact on your motor symptoms and how you feel your dystonia is affecting you. And the point of this study was to see what impact did these motor symptoms have and these depression and anxiety symptoms have on your overall quality of life. And this answers one of the questions that one of you brought up to Dr. Peel, is which of these variables, the Twisters variables, which is pain, disability, that's a survey that looks at how your dystonia affects your quality of life. So it would ask you things like, are you able to do your cooking and your cleaning? Are you able to drive and go up and down stairs without any trouble? And then there's a total score when you add it all up, and then the anxiety or depression scores. So we had these 6 variables, and because we had such a large database, we could do a statistical analysis where we took the scores and compared them to our quality of life scores to get a result that would tell us which one of these variables had the biggest impact on quality of life. So, if you ask someone who doesn't have cervical dystonia or is not dealing with people with cervical dystonia, they might say, okay, maybe the pain or the motor symptoms is the biggest issue, maybe the disability is the biggest issue. But as a lot of you have mentioned, these are the scores that we had, and it's a score from 0 to 1, and the higher the score, the bigger the impact, and the anxiety scores were the biggest influences on quality of life. And this is not the ideal way of carrying out a study like this, because we don't have an ideal way of measuring this, but it certainly lends a lot of evidence to what we've been talking about already. And again, it reinforces why we bring up anxiety or depression symptoms so much in our clinic. It's because of what our own research has shown. And you can see here the actual motor severity, which is the Twisters severity score, didn't have that big an impact at all, with a score of 0.4 compared with 0.01. The second study that Dina looked at was how does mood disorder, what are the differences between those people that we said had mood disorder before they developed dystonia? How do they differ from the people that had mood disorder after they developed cervical dystonia, which again was one of the things that you brought up with Professor Peel. And this is something that Professor Hutchinson has been very interested in, because he's always had this hypothesis that whatever is driving the dystonia is also what's driving the anxiety and depression, and it's not just purely a response to the motor condition. And he's probably said this to a lot of you, and I've said this to a lot of you. And we don't have much evidence to support this, but it's just a hypothesis that our own research group has been working on. And this is what Dina wanted to look at in her second study. So this didn't include all 201 patients, it included 193. We looked at the history of anxiety and depression before and after they developed cervical dystonia, and we focused on the anxiety depression scores and the Twister scores, which I've explained to you already. And this is the only result that I'm going to bring up from this study. So what this shows here is the age of onset of dystonia, so what age people were when they developed dystonia, and this is only the women. So the blue triangles, this line is the women that had anxiety and depression before they developed dystonia, and these red circles are the women that had anxiety and depression after they developed dystonia. And the difference between these two were that we found that the blue triangles developed dystonia at an earlier age, around 42, and the red circles developed dystonia around 48. So whatever is going on, whatever is causing this dystonia, is predisposing the people with anxiety and depression to develop it at an earlier age. So if you had these psychiatric problems already, you were then going to live with cervical dystonia for a longer period because you develop it earlier on. And why is this happening? Is there something about developing anxiety and depression that predisposes you to developing cervical dystonia? Or is there something else that's underlying all of this? Or the other answer could be are these people that have anxiety and depression, are they having really subtle motor symptoms that we don't recognize, that maybe they don't recognize that's impacting their quality of life? A lot of this is being discussed at the Dystonia International conference that's happening, and there's no answer here. But this is just one of the things that we found in our study, so it's certainly worth exploring. So the two main outcomes that we found were that the mood symptoms, as we've talked about already, have a bigger impact on the quality of life, and we can say that mood and cervical dystonia have a very complicated relationship, and that's about as specific as we can get. So my own work, which is from 2020 to 2023, was building on some of the work that Dina did, and we focused on building on the psychiatric symptoms, and we focused on some of the cognitive symptoms as well. And I'll come to why we started looking at the cognitive symptoms, and particularly in people with anxiety and depression. And again, I'm going to answer one of the questions that you guys posed to Dr. Peel. One of the first studies that I did was, how does the mood symptoms change with the course of the disease? So the very first study that looked at this was back in 1990, and these two people, Marjan Jahanshahi and Charles David Marsden, they were two big pioneers in dystonia research, and they really kind of set the stage for what dystonia research is going to be over the next 20 or 30 years, and we're still building on the work that they've done. And they took the people from their clinic and they followed up the depression, disability, and body concept, which again is how you view yourself if you had cervical dystonia. And what was their conclusion? They said those whose torticollis improved were less depressed. So that's not really something you can argue with. So when you have cervical dystonia and start getting botulinum toxin treatment, your anxiety and depression symptoms, intuitively you'd think they were going to improve, and that's what these guys showed. This was a small enough study, and it wasn't a very rigorous study in terms of the number of measures that they used, but it was one of the first, I think it was actually the first study to look at this back in the early 90s when the dystonia researchers started turning to the non-motor symptoms. The second study was 25 years later. This was from Italian neurologists in Italy who looked at again, the clinical course of psychiatric disorders in people with cervical dystonia, and they took people 5 years apart. So they first measured mood symptoms and then did it again 5 years later, and here they concluded that there were no differences in the mood or anxiety symptoms or the severity of these symptoms between the two evaluations, even though the motor severity of dystonia was milder at the second evaluation. So this goes against what the first study showed. So they said that even though these people's motor symptoms improved, their anxiety and depression didn't improve, and that's their conclusion. And one of the downsides to this study was it was a very small study. I think they only included about 20 people, but this was only the second study that was there to look at this. So this was the background with which I carried out my own work, and we took 52 patients and we looked at them 24 months apart. So Dina's study in 2018 and 2019, we then looked at them again in 2020 and 2021, and we went back and looked at the mood, anxiety, and quality of life scores. And this is the only set of results I'm going to bring up from this study. So we have our phase 1, which is the red lines, the phase 2, which is the black lines. So let's look at the anxiety scores. We know from Dina's studies a score of about 11. My study, still a score of about 11. The depression scores, 2 years ago, score of about 11. My study score of about 11. And then again, the motor severity was around the same, and the quality of life stayed the same. These are all people that are already being treated with botulinum toxin, so that's one of the reasons why the motor severity didn't improve, because they were already established on treatment. What does this tell us? That the anxiety and depression doesn't tend to get any worse. It's not a progressive aspect of the syndrome. It also doesn't improve. So, like Dr. Peel hypothesized, it's something that seems to just plateau once you develop your cervical dystonia. Maybe it improves a little bit very early on in the disease, but it doesn't tend to change too much. The next step of my own research was shifting to cognition. So this is your thought process, apart from mood, in people with cervical dystonia. And we built on work of Dr. Fionnat O'Keefe, who was a neuropsychologist who was working with us, who some of you would have met. She had a psychologist, master's student who's working with her, Ruth Monaghan, who was very interested in cervical dystonia. And they did a very comprehensive psychological analysis of 46 people with cervical dystonia. A lot of you would remember this, where you just go in and you sit down, and she does a very comprehensive review, just one-on-one, going through various different aspects of cognition, a lot of different tests, and it's quite a tiring test. I've gone through them myself. It takes about an hour to 2 hours, and you'll be exhausted by the end of it. And what she found was that people had some changes in social cognition. Okay, so out of all the different cognitive domains that she assessed, as you'd expect, looking at all of you, dystonia isn't a degenerative condition. You know, you're not a group that are expected to have changes in cognition like people with Parkinson's disease or multiple sclerosis. But there were these subtle changes, and they were very subtle. They were very minor if they were there in social cognition. And social cognition is quite a complex entity, and it's difficult for me to even define it. But to put it simply, it's the way you understand the emotions of others. It's the way that you can read body language from other people. It's the way you can look at someone's facial expressions and say that they're in a happy mood or in an angry mood. And you can figure out people's emotions from their tone of voice. And the single biggest study that was done in social cognition in cervical dystonia was very recent, and these researchers are there at the Dystonia conference talking about aspects of this. This was published, I think it was just last year or maybe 2 years ago, and they included a lot of people with cervical dystonia from their Canadian hospitals, and they did an extremely comprehensive analysis of social cognition, more comprehensive than the ones that we did. And what were their conclusions? So they said, contrary to our prediction, generally intact social cognitive abilities were found in most participants. So this goes against what our study showed and what some other studies have showed as well. But then there was a caveat to this. They said, however, facial expressions of fear were much less well recognized than other expressions. So one of the tests that they would have done, where they would have been shown pictures of different facial expressions, mild and very obvious facial expressions, and they would have been asked, what do these expressions represent? And they concluded that the expression of fear was something that wasn't that well recognized. So these are what the facial expressions would have looked like. So I've blacked out what these expressions mean, but if you want to try and figure these out yourself, I would expect all of you to get at most of these. Okay, obviously this man is smiling, so you know he's happy. This guy's frowning, you know he's angry, sad there, maybe surprised there. Maybe it's a bit of difficulty telling the difference between these two, because we use a lot more than just the facial expressions. We use body language, and you know, when we look at faces, we look at the hair and the neck as well, and how the neck is postured. So this is fear, this is surprise, and then this is disgust. Most of you would be able to get nearly all of these. I couldn't get disgust, so there's a normal range for this. And the facial expressions are very important. Your brain is really well specialized at recognizing facial expressions. That's because it's a very human thing. Animals don't have facial expressions. So it's a really important part of childhood development, of baby development, that babies can look at their mothers and recognize their mothers' faces. And that's something babies can do within a few weeks. And we can all, in general, tend to tell what expression is on other people's faces. And this is thought to be one of the reasons why humanity has developed so well, the way that we can read each other's body languages. And the research has gone on in this for at least about 60 or 70 years. So back in the 40s and 50s, people started looking at this and studying what aspects of the brain are focusing on our ability to recognize faces and facial expressions. And these are three of the structures that are very specialized. So the SC is the superior colliculus, there's the pulvinar nucleus, and the amygdala. And they're three structures that work in a network, and they focus on face recognition, firstly, through vision, which is what you need. You need to be able to see people's faces recognize that you're looking at a face, and then recognize the emotional content of the face. And these are three of the areas that are very involved in that. And they connect to lots of other regions in the brain, so they're not working in isolation, but if you have damage to these, and the people that have damage to these through strokes or through other head injuries, they have some difficulty in recognizing facial expressions. So one of the studies that I did that some of you would have been involved in was my EUG study, which you would have been sitting in a chair, and we would have put this red cap on you with all these wires coming out, and we had a very high-tech setup that we got from the engineering team in Trinity College, where we had 128 leads. And we were looking at the electrical changes in the brain as you were viewing facial expressions. And this is something that has been studied before, so we know what changes in electrical activity to expect if you have a normal response to facial expressions. So we took 12 people with cervical dystonia and 12 age-matched controls from Vincent's, and they tended to be some of the nurses that we worked with and some other friends who were interested. And people in the early 40s took part, and they had a mean disease duration of about 8 years. And I had never told anyone that took part in the study what the actual outcomes were, so if any of you are here, you might be interested in knowing about this. So you were sitting in a dark room, you had that setup on, you were in front of a laptop which was displaying all these facial expressions on the screen, and they flashed up very briefly, so only for about 100 milliseconds, which is all it takes for your brain to recognize the face and the facial expression you're looking at. And there was a reason that we kept it that short, because we didn't want there to be other areas of the brain to get involved in this. And what do we find? So this is the kind of data that you get back. So these are the waveforms that we would extract from the software that reads the electrical activity in the brain. A lot of this is very new to me, so I don't have a very deep understanding of a lot of this. This would be the work of neurophysiologists. But we took these specific waveforms because we know that they're the waveforms that others have discovered to be associated with facial expressions. And then we compared the people with cervical dystonia to people without cervical dystonia. And what we found were that there was a difference between these waveforms when we compared the two. Now, does that mean that it's an abnormality? Not necessarily. It means that these areas, the electrical responses are different. Does that mean that there's a social cognition abnormality? No, because you can't use these waveforms to diagnose people with anything. But it would certainly suggest that that network that I spoke about, that the electrical activity that this is producing, this measures electrical activity on the surface of the brain, but the electrical activity is then connected to areas deeper. It would suggest that there's something that's different about this. That's as much as we can say. We can't say it's an abnormality, we can say that there's a difference that's going on. The next step would be to actually focus on these areas specifically. And to do that, we had to do an MRI scan. We had to do a fancy MRI scan called a functional MRI scan. And again, a lot of you would have been involved in this. You would have been getting into that tunnel, and you would have been sitting in there for about an hour, which again, is something that's very scary, but some brave people with cervical dystonia kindly volunteered to do that for us. And here again, they would have had a screen in front of their faces, which is flashing the exact same facial expressions that you would have been looking at if you had been involved in the EEG study. And this is the same paradigm. And what did we find here? So this is the superior colliculus, these little red and yellow areas. And from these MRI scans, we can actually measure activity that's going on in the brain. And this is a study that only finished very recently, just in the last couple of months, and we're still analyzing the data. But the very first impression that we have from some of the data analysis is that is shown here. So if you look at these black bars, they're people with dystonia, and the lighter bars are people without dystonia, so the nurses. And we looked at the response in these areas when you were shown that expression of disgust. And what we found was that the response that you had in the brain was a little bit lower in disgust than the people without dystonia. Again, this is not a diagnosis of anything. This is just to indicate that there is something going on in these areas in the brain. Maybe this is what's causing these social cognition changes, keeping in mind that there's still no international consensus on whether they're real or not, but certainly in our own clinic of people with cervical dystonia, they seem to exist. And this is some of the interim results. So this is one of the first studies to actually show this, and we'll still be doing more detailed analysis over the next few months to get this out into a paper and to disseminate it to other researchers. Professor Hutchinson is very focused on this network, which is why we put so much attention into this. And I think this is actually one of the first studies, or actually not the first study. The first study was done about 7 or 8 years ago by Dr. Ivan McGovern, who did a very similar study, and some of you would have been involved in that. But certainly there's very few studies that are looking at the superior colliculus and its role in cervical dystonia. Even now at the Dystonia International Conference, Dr. Fearon gave a talk where he was telling people about the importance of the superior colliculus, but there's no one else that's really focusing on this. And I want to come back to this, again, touching on what Dr. Peel mentioned, is that dystonia has a lot of tenets to it. So we have the dystonia severity and the tremor at the top. And we, because of the research that we have been doing, thanks to the involvement of all the patients, we have been able to tell that there is so much more to dystonia. There's all these aspects of quality of life, and then there's all these aspects of mood, and then what's missing here is our cognition as well. And the people that are doing the research, they would have very detailed testing done, and we do tend to try and ask people that are attending our clinic because of the work that we've been doing. But really, feel free to tell us, volunteer this information to us, because we know that whatever is happening in the background in your life is going to impact on your motor severity as well. So if you are someone who's not responding too well to botulinum toxin, one of the first things that I would always ask is, how's your mood? How's all the other things in your life? Because we know that this is going to impact on your response to treatment and your motor severity and your pain as well. The people who have anxiety and depression probably have a bit more pain associated with their dystonia. And in our own clinic, we're probably a bit more liberal about giving antidepressants to people simply because of our own experience in how well it does. And there is this very unnecessary fear of inducing a movement disorder as a side effect. And one of the talks I was just at this morning was talking about it. But again, the conclusion is that that side effect is extremely rare. And the potential for these medications to improve your anxiety and depression is well worth the risk. And certainly the people that I've started antidepressants on, they've had an overwhelmingly positive experience. And I don't think anyone in our own clinic has come back and said that their dystonia, the motor symptoms, have gotten any worse. So I'm finished now. My own work ended a few weeks ago, and Professor Hutchinson, as you may have noticed, is also no longer in the clinic, and Dr. Fearon is taking over, leading the research group. And there's still going to be a lot of work that's going on, and we're still going to be focusing on this small area at the back of the brain called the superior colliculus. And, any one of you, we're still focusing on cervical dystonia, but if you have other forms of focal dystonia and you're interested in getting involved, then let us know. We'll keep your name in our database, and if there's a study that's appropriate for you, we can certainly get you involved. And we're always trying to expand our research to outside of cervical dystonia as well. But a lot of our research, the theme of it is going to be focusing on the role of the superior colliculus, with the intention of trying to figure out what areas in the brain are actually causing this, because we still don't really have any answer. And all these hundreds of international experts with decades and decades of experience between them, and all these talks, there's still no consensus whatsoever on what part of the brain is actually causing this. I don't know why that says research 2023 to 2023, but it's going to be lasting a lot more than this year. We have a new study planned that's going to be looking at, again, the superior colliculus and cognitive functions of the superior colliculus. We're looking at something called perceptual decision-making, and that's because a very new study showed that this area in the brain has a very prominent role in that, and that's not something that's well studied, so we want to look at that in people with cervical dystonia, and we're doing that by EEG. It's not going to be as intensive as the EEG we did before. We're using slightly more modern equipment and fewer leads. It's going to be somewhat of a nicer experience, so if you're interested in getting involved, please let us know. And we're also doing posturography, and this is because of the collaboration that we have with the engineers in Trinity College, Professor Richard Riley, who's giving us some of his equipment. So he has designed a balance board, which is a very simple board that you step on, which measures your gait, your center of gravity. And we know that if you have an abnormal posture, you're probably going to have slight difference in how you hold your body and the way that you walk. But there's no real detailed study that has been done looking at that, so we want to do that over the next 12 months. And we also have a new sensor that our engineers have designed for measuring dystonia severity. One of the things that I don't like doing and Dr. Fearon doesn't like doing, and I know that all the people that we've been studying in our own clinic don't like this. It's all these paper-based surveys that you hand out, and it's just a tick-box exercise. So we're trying to see, is there a better scale for doing that, certainly for measuring motor severity, and the engineers have given us a new sensor that you can just attach to your head. And I tested that in a few people from clinic a few weeks ago. I don't know if any of them are here, but it certainly seems to be working, and we want to do that in a much larger study. So that is going to be happening over the next few months as well in people with cervical dystonia. And let me finish by saying a big thank you to all of you who have been involved in our study. None of the work that we have done over the past 20 years and the work that Professor Hutchinson had done, even though it's coming from one clinic, has had a big impact in the dystonia literature internationally, and we've contributed a lot, and a lot of these researchers here are bringing up the studies that Professor Hutchinson has done even up to 15 years ago, because they're one of the first studies that have shown whatever changes that they showed back in the early 2000s, and it's still having a big impact on the dystonia research community. Let me also thank Maria and Dystonia Ireland. The functional MRI study that I did was in its entirety funded by Dystonia Ireland, so that study would not have happened without your support, so thank you for that. And for all, the funding of all the other studies that you guys have supported over the past decade or so. So a lot of the work we just wouldn't have been able to do without the advocacy work of Maria and Dystonia Ireland. And I think that's it. I'm happy to take any questions.
So, just echo what Shamir said about the funding and the support we get from Dystonia Ireland. It's really fantastic, and we couldn't do it without it. It's lunchtime now, but are there any burning questions that anyone would like to ask Dr. Rafee?
I didn't realise how long my talk had
taken.
taken. Apologies.
It was perfect.
Sorry.
Oh, yeah, I'm not sure what I'm doing, but whatever I do, it seems to work.
I'll hang around for a few minutes. If you want to come up to me afterwards during the break as well, feel free to.
First of all, to say this is my first time to come in 25 years. I was diagnosed in 1998 when I was studying theology. And to give hope to everyone here, to tell you that I've since studied theology in 4 or 5 different colleges. So the dystonia hasn't stopped me. It's actually helped me maybe in some ways to work even harder. I just want to ask the question that I asked some years ago to Dr. Michael Hutchinson, and thank you to everyone here who has been attending all the years when I didn't attend. So to make it possible for me to come and get these results today, I thank you so much. Just to say, are there rare cases where dystonia actually disappears? Just wondered about that.
Cervical dystonia certainly can go into remission, and that remission can be very variable for several years, 5, even longer. I think there's been people in our clinic who have had remissions for up to 8 to 10 years. I haven't seen anyone certainly to have an indefinite remission. I think certainly from the studies that I've seen that if you have cervical dystonia and you go into remission, it is almost inevitable that it will come back at some point. I don't know what your experience has been.
I agree with that. It's rare, but it happens, but it tends to be a more prolonged remission rather than a complete reversal of it.
Thank you for that. Appreciate that. Thank you so much.
Hello, my name is Miriam, and I have Miege syndrome and facial dystonia, and yeah, I don't really know what to ask, but I just find it, my pain is all emotional pain, and yeah, look, I just wanted to say it's more Miege and all my bottom lower face area.
Thank you for being here. So the next speaker after lunch is Professor Lang, who's going to talk about the classification on diagnosis of dystonia, and he may cover some of these slightly rarer forms, and even just to hear somebody who's an expert in the field talk about it is sometimes even helpful. But we're increasingly recognizing, as we've talked a lot about today, the non-motor burden that people who live with dystonia experience. And I think those questions asked Professor Peel, that this ends up becoming much more of the source of disability than some of the motor features we've
A hidden disability,
Absolutely.
I feel, at times.
And what I would suggest is a lot of people don't volunteer these symptoms. I know from our clinic we've been asking you from a research perspective, but there's some people that would never have been involved in our research. So I'd say be a bit more open about it, talk to your GP, bring it up if you have the opportunity to do so. And there are lots of treatments for the non-motor symptoms, so don't exclude yourself from that because you think it's not related to your Mesh syndrome. It doesn't matter. If you have anxiety symptoms, they can be treated as anxiety symptoms, and treatments work.
I found that a tablet, Xanax, really, really helps. And I can feel like a normal person when I take it, but they won't give it to me. I can't understand this. I really can't understand this.
So I mean, we can talk again about individual treatments for things. There are lots of different ways to treat anxiety, and I think a lot of people feel that benzodiazepines may not, like Xanax, may not be a good long-term solution to it because the body unfortunately becomes quite tolerant of these medications. But they're very helpful in the short term, and I'm not surprised that you find it hugely beneficial. But sometimes you need a sort of a longer course approach to some of these problems. But it's very tricky. Might take one more question if there is one. If not, we might break for lunch. Great. Thank you, Dr. Rafee. Thanks very much. So we might take a bit of a break for lunch, and then we'll start again at 1:30 as planned, if that's okay. But thank you.